Okay.
Yeah.
We're all set. So, thank you again for agreeing to do this.
Oh, well, glad to help out.
So
I don't know how many. I don't think I had many pearls for you, but
No, I'm
we
sure.
just have a few things.
Yeah. So I was wondering if you could tell us about just why you decided to enter medicine to begin with.
About what?
About why you decided to enter medicine.
Well, I liked when I was in college, junior year, I had to decide whether to go in and get training to teach biology or go into medicine. And I always thought medicine had included biology plus much more to offer, and so I decided to go into medicine. And I never regretted it. I always chose surgery because I thought I'd like to be able to do something to help somebody right away and not just be giving pills. And surgery appealed to me, the technical side and the fact that so many things you could cure or treat right on the spot.
Yeah. And where did you go to medical school?
I went to Dartmouth Medical School from college up there, and that time Dartmouth Medical School was a 2-year school, and so we all had to transfer to other schools. I transferred to Harvard with about 3 or 4 others, and graduated from there in 1934. And then from then on there was internship and residencies for about 7 years.
Mm-hmm.
So I had a long session.
A long haul. So you decided to choose surgery because you like to help people right away?
Yeah.
Were there any other reasons that led to you choosing surgery over all the other specialties that are available?
Yeah. We, 3rd and 4th years of medical school, at Harvard, we had a chance to spend time in each specialty, nose and throat, and gynecology and urology and obstetrics and all that. And I liked surgery. In fact, I was quite interested in what I saw at Children's Hospital, so I started there, and I had 6 months of pathology and then went into surgery. Dr. Ladd, who was an outstanding surgical pediatric surgeon at the time, he did a lot of new techniques and things that I just like taking care of children and like the atmosphere at Children's Hospital.
Is that where you did your residency as well, over at Children's?
Well, I went on into, when I got along in children's surgery, although I liked it, I decided I better get a training in adult surgery as well. So I went on to the Deaconess, and I had a residency at the Palmer Memorial wing of the Deaconess, and Palmer Memorial is where many of the doctors at the Mass General treated their private cases, and we actually assisted and more or less took care of these patients after surgery. Some of the chief surgeons in Boston, not only in general surgery, but in obstetrics and, in gynecology and urological surgery as well. So it gave us an opportunity to see how a variety of surgeons handle cases. A lot of them cause cancer cases, and we learned good points and the things to avoid doing, and I thought it was an extremely valuable training. And then from there I went on to surgical resident in New York. That time the chief surgeon was Dr. Elding, who was surgeon from New York Central, and he had a large practice of railroad casualties and things like that, which we had a year out there. And also they had an excellent thyroid surgery service. So
so did you do 3 different residencies? One at Children's, one at Deaconess, and then one at New York?
Yeah. What's that?
Did you do 3 different residencies?
Yes. Well, then I went on to they came back. I had 4 or 5 months before I started the State Cancer Hospital in Pondville, Massachusetts State Cancer Hospital. So in the interval, I was a fellow at the Leahy Clinic, and got a chance to work with Dr. Cattell and Dr. Leahy and many of the other surgeons who were very outstanding at that time. And then at Pondville, that's a state cancer hospital where cancer cases, at that time, treating cancer cases were pretty much centralized in the teaching hospital areas. And some of these outlying hospitals would refer the cancer cases to Pondville, all kinds, head and neck cases, and of course cancer of the breast and the thyroid and stomach and bowel and all that. GI, we didn't do much lung cancer surgery out there. That was done elsewhere. But the staff were doctors from the Mass General who were doing cancer surgery at Mass General. They'd come out, and Dr. Dalen, who was very well known, and Dr. Meggs, who was head of the GYN cancer service, that time treating cancer of the cervix and uterus was being developed, and he did a lot to get started in treating with radium and implants and X-ray and other cases, total excision, that sort of thing. So that was also valuable. I was there for 3 years. Last year as chief resident and assistant superintendent of the service. So that's, and I came to practice here in Worcester at 41, April 41.
So that was your 41 was the first year you were practicing on your own?
Yes, I just started out.
And where did you practice in Worcester?
Well, I got an appointment on the Memorial outpatient. I was invited to come to Worcester, as a matter of fact, through Dr. Alden, who was chief surgery at the Memorial Hospital. And so when I arrived in Worcester, they tried to keep me busy, outpatient, and I also went up to Norton's. They had a little hospital, and I used to go up there, and I think most every afternoon, I think, to see. They had a lot of trauma, hand, finger injuries from the machines and so forth, so that gave me a chance to get started.
So what type of surgeries did you do at the beginning of your career?
Had what?
What types of surgeries did you normally do on a routine basis?
Well, it's usually outpatient surgery, traumatic, till you get going, and I soon began to get case referrals, and I was in practice about a year before I enlisted in the Navy in the November 41, 42 I was. And I went down to Philadelphia for indoctrination, and then was assigned as surgeon on the one of the new aircraft carriers. And they, when the war broke out, they wanted a lot of fast carriers that could help invasive maneuvers to keep away from the Jap subs. So they had these medium-sized carriers. At that time, they didn't have many of the large carriers. They had just about 1 or 2, I think. And so they needed these medium-sized carriers they could build faster, and they had a fighter squadron and a bomber squadron, and we were out there, and for about 3.5 years, we were in practically every major campaign, retaking the islands until right up through Iwo Jima, and then we came back at the end for repairs, and the next month they dropped the A-bomb in Japan, so we saw most of the activities the U.S. regained control and started to destroy the Japanese Navy.
So did you handle a lot of the war injuries?
Yes, we had many pilots who come back with gunshot wounds, and if they came back at all. And then too, we had a lot of injuries. As in the rough sea, the level of the flight deck would change 20, 30 feet, so they might come down planning to land at 20 feet, and the flight deck would be down below, and if they didn't get enough speed to take off, they'd have to land in the gun mounts, and they'd wipe out some of the Marines who manning the gun mounts. We had casualties, but fortunately not too many.
How was it like to be in that sort of situation in the middle?
What's that?
How was it like to be in that sort of situation, just in the middle of a war, having to treat people coming back with gunshot wounds?
Well, we had a well-equipped surgery, and I trained the corpsmen to run the OR, and we give anesthesia and do what's necessary. And we had a staff of about 20 corpsmen, and there's a medical doctor and a medical doctor assistant and a flight surgeon who actually was a nose and throat fellow, but he was trained to take care of the pilots, tell them when they could fly, or whether if they had minor things, medical problems, they'd take care of those. But the pilots had gunshot wounds and injuries, that's all we took care of in surgery. Fortunately, and anything that was really bad, we'd do the best we could with it, and then fly them off as soon as that immediate engagement was over. We'd be in engagement for about 3 weeks, and then go back to atoll for resupply and refueling, and in the meantime we'd unload the seriously injured ones and get more supplies for the next operation the next month.
Was it emotionally a difficult thing to deal with?
Yes, sir?
Was it emotionally a difficult thing to deal with, seeing...
Oh, yes. There's nothing pleasant about it. No, war is a horrible thing, and hope we don't have any more. But the courage of the flyers was just amazing. They'd, off Iwo Jima, about 30-foot seas and cold and rough, they'd take off and never knowing whether they could find the ship again and get back on if they did. And some of them would get shot down. We'd do our best to try to find them and pick them up.
And was it difficult to come back to practicing medicine within Worcester after going through an experience like that?
Well, no, it was good to be back with a stable situation and a well-equipped hospital and a friendly, good staff to work with and all that. Those things we remember them, but we're glad that they were in the past. Yeah.
So now, you did surgery, so you came back from the war about 44, 45?
46.
46?
Yeah.
And then you started practicing again?
Yeah.
Right in Memorial, or?
Oh, yes, Memorial, and again, was in the outpatient. I had charge of the blood bank then, and I went to Norton's for a while, but I soon got so busy, I just didn't have time to go out there afternoons, and getting started again, quite a few of the older surgeons asked me to help them on their cases, and Dr. Hunt was one of the leading surgeons in Worcester at that time. He was I guess about the only one who was a member of the American College of Surgeons, and he did a lot of surgery at Hanneman and Fairlawn Hospital, and if he had a case up there, he'd ask me to help him with it and so on. And then helped some at Memorial too, till I got so busy I didn't have time to do that.
What type of hours were you usually working on a given week?
Well, I'd usually get to the hospital about 6:30 in the morning, and we'd start runs at, 6:30, 7:15, start rounds at 7, and then we'd start surgery about 8, and then I'd have office hours from about 2 to 5, and then I'd go back to the hospital and see the cases we'd done during the day and make sure everything was going all right.
So what time would you usually get home on an average evening?
Oh, 7 or 7:30 or something like that.
And how were the rounds at the hospital? Did you have medical students that you had to
Oh
see?
yes, we did. That was fun. I enjoyed that. We had boys from Canada and Central America and Cuba and later India and of course England and Iceland. At that time they had the Vedna Foundation, and in Germany any student in the top 10 of his class in medical school who wanted to come over to the U.S. to get further training, they could apply, and quite a while came to Memorial, and we'd have them some right through their whole 4 years of surgical residency. And Dr. Spanknabel came over in that program, and he was surgery for a year, and then went on to get interested in gastroenterology, and he's now one of the leading gastroenterologists in the city. You know, as well as active in the medical society.
And how long did you practice at Memorial Hospital?
How long did I?
Yeah.
Till about, I think I stopped about 82. I was about 73 at that time, and so I decided I'd better take a little time to do some traveling and things I hadn't had time to do before.
So you mind if I ask you how old you are now?
That's right?
You mind if I ask you how old you are now?
Yeah, I'm 92.
92, wow, that's great. You look great for 92.
91, I mean.
91?
Yeah.
So you must have saw a lot of changes over the years that you were practicing.
Oh, yes. When I was in practice, I had a secretary who was very efficient, very well trained, and she ran the office. She'd do the counting and the booking and chaperoning and take care of the office. And then as I was leaving, about in the 80s, we had to take on a couple more to keep up with the paperwork, and I turned my practice over to Dr. Dykhuizen, who I think he has 3 or 4 people in the office there now. He's doing his general surgery the way I did.
So the amount of paperwork that you had to fill out for every patient?
Yes, all these HMO forms and all that, it just got to be more than one person could handle, and this, so I'm glad I don't have to cope with it. I guess I hear it's getting more complicated every year.
Yeah. So you must have seen a lot of political changes within medicine.
Yes, I think the greatest change in medicine is that doctors feel so rushed in seeing patients now that they really don't have time to get well acquainted with them, and I'm not sure how much time they spend in the follow-up after surgery. I've heard various reports that sometimes the patients don't see the surgeon very often after surgery, and that's just too bad, because I think somebody coming out of surgery likes to know that whoever did it feels responsible, and they take an interest in the recovery and make sure that everything's going well. So,
Do you think there's anything we can do to, as a
What?
young doctor, is there anything that we could do to change the system or to bring it
well,
back?
I don't know. There's no simple solution, I'm afraid. This doctor's willing to budget their time better, but I think it's an individual matter between the doctor and the patients, which some feel a little more responsible than some of the others may be.
So when you were practicing, Medicare and Medicaid probably came into effect around the 60s.
Yes, I think that was a great thing. Before that time, that patients didn't have insurance. They'd come in the emergency ward and they'd get taken care of anyway. And whether it's a surgical emergency or just some minor problem or chronic problem, and I think the city hospitals took care of the people that didn't have insured. But of course, a lot of those people wouldn't bother to come in the hospital until they were about dead, and then it's hard to disadvantage in being treated.
So how did Medicare and Medicaid change all of that?
Well, I think they probably come in a little better. There's still a certain percentage that don't seem to be covered or don't seem to get care, and that's, of course, quite a concern for everybody in the health service.
And what about the advent of HMOs coming in and
Advent of what?
HMOs coming in and changing around?
Yeah, well, they may have helped some too, but of course they were just beginning to come in when I dropped out of surgery, so I really didn't have much experience with it.
Do you think it's affected the care that's given to patients?
Oh, I think so. I haven't heard many complaints about it.
So now, just to back up a little bit, just to talk about other things that have changed over the years that you were practicing. What about new technologies and new techniques?
Oh yeah, of course, heart catheterization was coming in, open heart surgery was coming in, and kidney dialysis and the treatment of burns improved greatly as they learned to culture skin cells and all that to make artificial sheets to cover burns. That when I first started in practice, bad burns, there's no, I think the burn service, the Mass General, was just starting up about that time, and we referred some of our bad burns into there, but the lesser ones we took care of out here. And first they used tannic acid, and then other things came along which are much better treatment, burns. So that was a great improvement. And then skin grafting techniques, so we did that too for a while until we got plastic surgeons who came on board at the hospital, and they sort of took care of all that type of problem. But for the first 5 or 6 years when I was in practice, we did all those things.
Was there anything that really allowed you to treat patients better? Any new technologies besides?
Oh, well, of course, the antibiotics and better intravenous fluids and improvement of blood bank and all that sort of thing. You could. Antibiotics are probably one of the great advances in treating patients, not only surgical things, but medical things as well. Pneumonia and some of the various strep infections that were pretty severe, and of course meningitis, which we don't see very much.
So before you had antibiotics, did you see a lot of infections after the surgeries, after the operations?
No, not too bad, but you'd see some that they had pretty good aseptic technique, so that wasn't a major factor. But if people came in with bad infections of the legs or arms, particularly diabetics, that antibiotics were quite helpful.
And as far as techniques, were there any new techniques that came out that allowed you to better treat patients?
I'm sorry, I can barely hear.
Oh, I'm sorry. As far as new techniques, like new methods for doing things within the operating room?
Well, the new technique of operating with small instruments through a small incision, that all came on long after I left. So we never tried to learn to do that. It just hadn't been established. We did have stapling equipment for bowel surgery. You could do end-to-end anastomoses with these staplers, and they were pretty good. And that was very good for low carcinomas of the rectum. You could do a resection and bring the ball out and use these staplers in areas that would have been difficult to work with ordinary instruments, but these staplers were quite a fantastic step forward. And I think that's one thing we didn't. At first, we used to see a lot of bleeding ulcers of the stomach, and ulcer problems, and stenosis, and obstruction, and all that. And towards the end of my practice, for some reason or other, cancer of the stomach became very rare, and also bleeding ulcers. I don't know. I imagine some people still have them, but they weren't the problem towards the end of my practice that they were 15 to 20 years earlier. That's one of those things I just don't know how to account for it.
Did you see any other changes similar to that? Like the needs of the community changing around at all? Or
Changing what?
the needs of the community, like the different surgeries that you would be doing, did they change as well? Like you had mentioned that you had seen less bleeding ulcers. Were there any other type of ailments that kind of changed in frequency?
Well, I don't know. We used to see quite a few thyroid adenomas and cancers, and I don't know how common they are now. They seem to be less common towards the end of my practice, but probably it's due to better iodine in the water and things like that. They didn't have as much thyroid trouble.
So you stayed in Worcester for your entire practice?
Yes. Well, I had a little break when I was finished my tour of duty at the Children's Hospital. I was waiting 2 or 3 months to start at the Deaconess. The medical school called up, wanted to know if I'd take a country doctor's practice up in New Hampshire for a couple of months while he went on vacation. Apparently, this doctor up in Lincoln near Loon Mountain had been a Harvard graduate, and he was doing general practice. But every year he'd like to take a month off, and he'd call down the medical school to see if they could find someone who was between their hospital assignments. And I had a couple of months, so I went up, and that was quite an experience. One of the doctor took me around to see his few patients he had, and a few came in. One of them was Sherm Adams, who was later vice president for Eisenhower. He was manager of a lumber operation there. Lincoln, New Hampshire is right at the outlet of a big wilderness area, and they used to bring logs and lumber out and process them somewhat in these places, sort of a mill down at the edge of town. And apparently he was somewhere where they got kicked by a horse and had a cut in his forehead, and that local doctor sewed it up, so I was take out his stitches. And then a few days later on, after he'd left, got this call from a young woman who she was in labor, and they wanted me to come up and deliver the baby. Well, of course, in medical school in those days, we had a couple of weeks junior year and again senior year in the district, when we'd go out in the district and deliver babies. I don't think they do that anymore, but we had experience in delivering babies, so I went up and had them boil the kettles, and I had some Lysol and pans. We dipped boiled all the instruments I used, and naturally, unfortunately, this woman had no trouble delivering the baby, so all I had to do was to cut the cord and see that everything was under control. And but that was the only experience practicing outside of Worcester.
So what drew you to Worcester?
What's that?
What drew you to Worcester? Why did you decide to stay and practice in Worcester?
Oh, well, when I got through at the cancer hospital, I was invited by this Dr. Alden, who was chief surgeon at Memorial at that time. I was invited to come out and practice here. So it was a great opportunity. They had a cancer clinic here at the hospital, and I liked all the people I met to work with. And Worcester's always stood the depression better than most other cities because of the diversification of the industry here. There's a lot of industry, the Norton Company and American Steel and Wire and Wyman Gordon and all the weaving mills and all that in this area. Seems though it had great potential for stability and good future as far as thriving and not having to close down, which has been true.
Was there anything that you disliked about practicing in Worcester?
What?
Was there anything that you disliked about practicing in Worcester?
No, I was very happy here. We used to we had a good teaching service, and I really had no complaints at all. We had a compatible staff, and they're a good medical society and so forth. So there's so much in the cultural society in Worcester, it's in the Art Museum and Music Association and things like that. There's a lot going on for anybody who's interested to take advantage of it.
And were you involved in the medical societies?
Oh yes, I was president of the Medical Society at one time. Then we had various other cancer societies. We used to travel to Europe once a year and have programs put on by cancer people in other areas. So that was all very rewarding.
Were you involved in any changes in medicine while you were president?
No, I don't think so. I think that's pretty much. I don't.
Or did you advocate for anything or anyone?
No. I think they've been trying to get through a good health plan. They have representatives in Worcester District Medical Society that go to the AMA and also we had a Massachusetts chapter of the American College of Surgeons, and they were active and had programs here and so forth.
So were you married and did you have a family at all when you were practicing?
Yeah, I got married when I was finished at Children's Hospital and had about a year and a half later had a daughter, and then a couple of months before I went in the Navy, my son was born, and so they stayed here in Worcester and survived, and so when I came back, we just picked up from where we left off.
How was it balancing your profession with family?
Well, I'm sure there are times when they got tired of my being away most of the day and into the night, and very often I'd try to plan something on the weekend, and something would come up, and you couldn't do it, you'd have to go to the emergency ward or something, so it's, but they gradually learned to live with it, and we always took a vacation and get somebody to cover, and so that sort of made up for the rest of it.
Did you find it to be a difficult balance?
No, not too bad. Not too bad.
Good. So you said you took vacations?
Yeah, we have a place up in New Hampshire where, on the lake where young people like to, it's sailing and swimming and boating and all that.
So you were able to schedule vacations for yourself even early on when you started practicing?
Doing what?
Were you able to take vacations even when you initially started practicing, or?
No, I don't think I did for the first couple of years. I think I stayed pretty close till we got things going.
Yeah.
I think that's probably par for the course.
Yeah. Do you have any fond memories that you look back on and remember?
Well, just some. No, I don't think I. We had some great trips and these meetings now overseas, and this New England Cancer Society. We went to England and Ireland and France and Italy, and those were all great. A lot of fun. We went up to Toronto and down to Texas, various cancer centers around, and they put on programs for us, which are always worthwhile. And then we had very good speakers come for teaching sessions at the hospital, too. We had outstanding people from other cancer hospitals, from Sloan Kettering and from MD Anderson and some of those other cancer areas, and they'd come up and speak about certain types of problems, cancer problems.
Do you have any memories that are difficult to look back on?
No, I don't. Nothing really major, I don't think.
Any like difficult cases or anything that?
Well, I remember the first Whipple cases we did for cancer of the pancreas. We worried a lot about how things go, but they all did all right. And I have one that was cured, but still lived on 5 or 6 years and died of a heart attack. But I think some of those problems are now being treated medically, so I don't believe there's so much of that type of surgery going on that that's
Is there anything else that you'd like to share or that we didn't touch on?
No, I just think that the most important thing, I think, is for doctors to try to spend time seeing the patients, get acquainted with them, follow them carefully after surgery. And I don't know if you've heard of Dr. Coop. He was a Surgeon General one time. He was a pediatric surgeon, and he's settled at Dartmouth, and he feels strongly about that point, and has been going around trying to talk to medical students to get them to realize that patients are individuals. They have emotions and reactions and apprehensions and doubt, and that's part of taking care of patients, is to help them through those periods when they feel apprehensive and so forth. And I think that's the main thing in dealing with patients that medical students ought to take into consideration and keep it on the top of their agenda.
Mm-hmm. So is that the kind of advice you would give to a young practicing doctor?
Well, yeah. Yes, I think that's very important.
I agree.
I think the medical people, primary care people, are needed as well as surgeons, but I'm afraid that in surgery now the tendency is things are so complicated, and there's surgeons are so busy they don't just take time to keep in touch with their recent cases and see that it all is going well. Maybe they assume it will because they did it, but I don't know. Things happen that just occurred for no apparent reason, that it's well to be on top of it if it does happen.
Okay. Is there anything else you'd like to add or share?
Well, I don't know of anything. I hope some health system is devised so so that more people not getting medical coverage will get it, and I don't know that we know the answer, except that the system they use in Washington seems to work pretty well. People buy different kinds of health insurance, and depending on how much coverage they want, and I think some system like that ought to be available, particularly for the lower income should all have basic coverage. Then if they want to be covered for open heart surgery or transplants and that sort of thing, they buy a little more insurance and to get the coverage, because a basic plan can't cover everybody for these very expensive operative procedures, and I think if people have basic coverage, why the major problems are going to be helped by having some solution.
Mm-hmm. What are your thoughts on socialized medicine?
Well, seeing the way it works in England and Canada, I certainly it's not been a success in either place, and I think the working out some of the plan where they would be very much preferable. I think when the government runs health insurance, it's there are all kinds of delays and difficulty and red tape in getting treatment and so forth. I think that's not the answer.
Mm-hmm. And I was wondering if you had any thoughts on
That's right.
just kind of completely changing topics. I was wondering if you had any thoughts on the cost of medical education today as compared to when you were going to medical school.
Yeah, of course, it's a lot more expensive now than it used to be when I went to medical school, but I think in general, many places, the ability to pay is not a determining factor whether they go to the college or the school. If you have a talented student with a lot of promise, why, I think usually the scholarships will cover them, so they, or at least a major part. So I think probably they're doing the best they can to hold expenses down so that those that want a medical education can get it.
Did you have to take out a large loan when you went to medical school?
Did I what?
Did you have to take out any loans when you went to medical school?
Well, my family, fortunately, were able to cover the expenses while I was in medical school. But a lot of students do take out loans, and some come off with a debt of $40,000 or $60,000, and which means that when they get through their training, when they're going to practice, they more or less have to go in a clinic or something where they're paid a salary, and I'm not sure that's the best system.
Yeah, some schools right around now are close to $40,000 a year.
Yeah.
A lot of schools are that way. So.
Yes, it's too bad that I think a lot of the schools are soliciting all the help they can, scholarship funds and things like that. And I don't know they can do much more about it. Their costs go up. They have to pay salaries for teachers and building maintenance of new buildings and all that, new equipment. So their expenses can't do much about that either. Well, I think that's about all I can think of.
Yeah. Okay, our time's almost up, and I don't have any more specific questions.
What do you think about the medical training situation?
What do I think? I think I'm very lucky to be going to UMass
Yeah,
because they have a learning contract.
you've had some good teachers and good instruction.
Yeah, we get some good teachers. A lot of the second year curriculum's changing around.